Hi, this is Ginger Keene, and we will be reviewing the AV block, ventricular, and pacemaker homework in this review. The first strip we're going to look at is 8.3. The rhythm is considered regular. The rate, there's two rates actually. You have an atrial rate and you have a ventricular rate. The atrial rate is what you see are P waves, and there's definitely more P's than QRS's. There's a P's, actually some of them are hidden within the T waves. So the atrial rate is 94, the ventricular rate 32. We're going to call those P waves sinus. The PRI, now we're looking at the PRIs where there is a P before a QRS, so we're looking at those PRIs, and they actually are constant, and they are pretty much 0.14 to 0.16, but they are considered constant, the same. Your QRSs are 0.10 to 0.12, and your QT intervals, so if you're measuring from the QT, from the beginning of the QRS to the end of the T, that is 0.68. Now looking at the interpretation of this, you have your R to R is regular, and as we did in the review of the AV blocks, your higher grade blocks, when you have more P's than QRS, so your R to R, if it is regular, it cannot be a Winky block. Then we look at our PR interval, so it is constant, so therefore it cannot be a third degree AV block. So we are looking at a second degree type 2 with a 3-to-1, pretty much looks like 3 P's to each QRS. Strip 8.8, looking at this rhythm, it is regular, but irregular because there is a dropped beat. So during the period where you have a P, but there is no QRS, that is considered a drop beat. So we have two rates. We have an atrial rate and we have a ventricular rate. If you do the atrial rate from P to P, that comes out to about 75. The ventricular rate, because it's irregular, we're going to say it is 70. The P waves that we have, they are sinus. So we have P's coming along, and they are on time. If you were to measure them out, you have one P that's extra, so therefore that puts us in a higher grade block. The PR interval varies between 0.28 to 0.32. So when you're doing your measurements, you can see that your PR is not the same. It is not constant. It varies. Your QRS is 0.06 to 0.08. Your QT interval, if you are looking at it, you have from the QRS, beginning of the QRS, to where the T waves, since your T waves are flipped, they have to come back up to the isoelectric line, so we are going to measure that as 0.36 to 0.40. Your interpretation of this rhythm is second degree type 1. Because the R to R is considered irregular, there are more P's than QRS, so that's why it does fall into the higher grade block. And with the R to R being irregular, it cannot be a complete hard block. And since the PR interval is not constant, it cannot be a second degree type 2. So process of elimination, we are second degree type 1. In 8.10, the rhythm is slightly irregular. If you look at the ventricular, it's off by just 3 boxes. If you were to look quick, you would say it probably is regular. Your atrial rate is regular, and your rate we're going to say is about 30s. You do have P waves. You have more P's than QRS's, and we're going to call them sinus. Now your PR interval. So your PR intervals we're measuring, again, from the beginning of the P to the beginning of the QRS. As you're measuring and you're noting, they are constant. So that PR is about 0.20, maybe 0.22, but pretty much they are considered constant. Your QRS, it is be about 1.5 boxes, so it would be 0.10. Your QT, it is starting from the QRS and it is going to where the T, some of it's really difficult because there's P's getting involved in there, but the QT interval is 0.64. So when you're looking at the interpretation of this rhythm, and it is higher grade block because there's more P's than QRS's, the R to R is pretty much regular. There's no longer drops, so it is considered, it cannot be a Winky Bach because the PR interval is constant. And that is the key thing to remember, that your second degree type 2 can be either irregular or regular, but the PR is constant, and that's the only one that has a constant PR in the higher grade blocks where there's more P's than QRS's. In 811, your R to R is regular. You have your atrial rate and you have a ventricular rate. If you were to figure out your atrial rate, that would be 60. Your ventricular rate would be 33. You do have P waves. The P waves are all over the place. If you look at them, some of them are hidden probably, but they are, you can see many of them. So there's more P's than QRS's. There's probably a P wave hidden in this QRS if you mapped them now. So, but the one thing is there are P waves, but that PR interval is not constant. It does vary, so there's no association between these P's and these QRS's. So the QRS measurement we are taking is 0.12. It's about 3 boxes, a little bit wider than normal. Your QT is 0.56, about 15 boxes. Now, because you have T wave inversions and ST depression, it is a little bit more challenging. So we're going to measure from the beginning to where it comes back up to the isoelectric line. And again, it's going to be longer because this is a bradycardia. And in the interpretation of this rhythm, because the R to R is regular, it cannot be a second degree type 2, and there definitely is more P's than QRS's. The PR interval is not constant, so it cannot be second degree type 2, so we are naming this a third degree heart block or complete heart block. In 8.5, the rhythm is regular, so your R to R's are regular. You only have 1 P for every QRS. Okay, so that means it's not a higher grade block. Your rate is 84, so you only have the one rate, the ventricular rate. Your atrial rate would be the same since they're in the same constant. The PR looks constant. There are P waves, we will call them sinus. Now this is where you measure your PRI. Your PRI is prolonged. It's 0.24 to 0.28. So you do have a prolonged PR interval. Your QRS is within normal limits of 1.5 to 2 boxes, 0.06 to 0.08. Your QT interval is 0.36 to 0.40. So for your interpretation of this rhythm, underline, you may just say that this is a normal sinus rhythm. And you can call that normal sinus rhythm, but it also has a first degree AV block. What also is significant is that you have ST depressions that are below the isoelectric line, so we want to make note of those ST depressions, and you probably would want to get a 12 lead EKG so that you can kind of confirm that there's nothing going on with that patient. And always check your patient, if this, especially if this is a new ST depression and a new AV block. In 829, this rhythm is irregular. The heart rate, we will do the 6-second strip, so we will say it is 50. There are P waves, okay, if you looked closely, they look pretty much the same. They're about the same, they are the same distance apart, okay. So you have P waves, and it looks like you have more P waves than QRS's, so we are in a higher grade block. So we have sinus for P waves. Our PR interval. Your PR interval is varying from 0.26 to 0.36. So we do not have a constant PR. If you measure your QRS, it is 2.5 boxes, so it would be 0.08 to 0.10. The QT interval is 0.48. So with that, our interpretation is it is a higher grade block, so between second degree type 1, second degree type 2, and third degree, the R to R is irregular, so it cannot be a third degree heart block. The PR is not constant, so therefore it cannot be a second degree type 2. So this PR is getting longer and longer, and then it drops, so we name this a second degree type 1 with T-wave inversions. In 832, the rhythm is considered regular. The heart rate would be 34. The P waves are sinus. There are many P waves. Some are hiding within T waves. So we believe they are going along. But the PR is not constant. So any of these P's before the QRS's are not related to that QRS. So we say it varies. Your QRS is a little bit wider, so it's 0.12 to 0.14. Your QT interval is 0.60. And our interpretation, again, since this is a higher grade block, we are going to use process of elimination. The R to R is regular, so it cannot be a winky block, which the R to R is always irregular because of that drop beat. The PR segment is not constant, so the PRI is not constant, so therefore it cannot be a second degree type 2. So this is a third degree heart block. It also, if you were to take your line and go along your isoelectric line, some of these are above the isoelectric line and you might have a little bit of ST depression. But again, you always check your patient, check your vital signs, do a 12 lead EKG. In 846, so this rhythm is actually considered irregular. It's kind of off by more than 2 boxes. So we're going to claim that heart rate to be 40. Again, if you're doing the 6 seconds, you're going between these 2 markers and you're only counting the R waves. So this R wave does not count. We are not, I'm going to make it X. That one does not count because it's outside that line. We do not count this T wave. It doesn't matter. It's only R waves that we are counting. And clean up my mess. So then, we have 1, 2, 3, 4, so we'll say 40s. We do have P waves, okay? So we have one P wave, we have another P wave, we have another P wave. So you see the P waves. These are not P waves. They look different. The morphology is way different than this P wave. These are U waves. So we only have one P wave for each QRS. The PR interval is long, it's 0.28, so from beginning of the P to the beginning of the QRS, that is 0.28. Your QRS is within normal limits, 0.08 to 0.10. Your QT is from your beginning of your QRS to where it comes back to the isoelectric line, and that is 0.40. So in this rhythm for interpretation, so it is coming from this SA node, so it is sinus Brady, but we do have a first degree AV block, and we do have a U wave, so these are U waves, not P waves, and therefore we would want to check electrolytes. Specifically, we want to check the potassium because hypokalemia can show evidence of a U wave, and a 12 lead EKG is also something you may want to consider. On strip 853, this rhythm is considered irregular. The rate would be 40, and just understand that the ventricular rate is irregular. The atrial rate is regular, if you were to map those out. And when we're looking at P waves, we have P waves, more P's than QRS's. They are sinus, so our SA node is working. Remember, your SA node is not the problem. Your SA node is functioning. It's the AV node that is not allowing some conductions to go down to the bundles of His. So when we look at our PR interval, it is 0.12 and it is constant. So all of these PR intervals are the same, okay? So that means they are constant. Our QRS is a little wide, it's 0.12, it's 3 boxes. Your QT is 0.48. And for an interpretation of this rhythm, there are more P's than QRS's, so therefore we are in a higher grade block. So we want to rule out it's irregular, so it cannot be third degree heart block where the R to R is always regular. The PR is constant, so therefore it would be a second degree type 2, and that's the only one that has a constant PR interval in the higher grade blocks. So we will interpret this as a second degree type 2 with a 2-to-1 and 3-to-1. So we see because we have 3 P's to this QRS and 2 P's to this QRS. So in 8.86, this rhythm is considered regular. The rate is actually 60. We do have P waves. They are sinus. The PRI is 0.24, about 6 boxes. The QRS is normal, 0.08. The QT interval is, now it's again because you have this flip T, so you want to go from the beginning of your QRS to where the T comes back up, and that would be 0.48. So the interpretation of this rhythm is first degree AV block because there's only 1 P for each QRS. You would basically call this a sinus rhythm or sinus Brady if it's below 60, but it is a first degree AV block, and the ST depression and T wave inversions would be something you would want to note. Check your patient, make sure that they're not having chest pain with this, because T wave inversion and ST depression could be a sign that they may be having an inferior wall MI, so a 12 lead EKG would be warranted. In 8.87, this rhythm is considered regular. The rate is actually 33. You do have P waves. They're there. They're small. There's probably one right in here. And if you were to look in, probably right in that QRS. So they're marching along. You can see they're small, but they're there. So we call that sinus. The PR interval, it varies. So you can't really get your PR interval because it's not constant. So it varies. So your QRS doesn't look too long, but it is wide. Oops, it is wide because you're counting between that big fat S wave. So you have a QRS of 0.12 to 0.14. Your QT interval is long. Again, that's realistic with a bradycardia. The slower the heart rate, the longer the QT, and that works out to be 0.68. So measuring from here to where it comes down to the isoelectric line. So let's talk about our interpretation. So there are more P's than QRS, so we are in a higher grade block. So the R to R is regular, so it cannot be a winky Bach. The PR is not constant, so it cannot be a second degree, type 2. So therefore it is a third degree heart block or complete heart block. Now let's talk about our ventricular rhythms. So 9-1. So we're looking at the rhythm, and actually it is considered regular if you're going from your, I guess you could say R to R's or S to S, but it is considered regular. So we do have a rate of 167. There are no P's, so we would definitely get rid of there would be no P's to put in there, and therefore there would be no PR interval. The QRSs are wide. And when you look at about how you would measure a QRS, it's very difficult to determine, exactly where you would measure one. And these, in the back of the book, it does say 0.12 to 0.14. But let's be realistic. If I see VTAC going across my monitor, I'm not wasting any time to measure those QRSs. I can visually see that they are wide. They are wider than normal and they are going fast. So we definitely don't want to waste time any measurements. So with that, an interpretation would be monomorphic VTAC. With monomorphic VTAC, we have a rhythm that is basically the morphology is looking very similar to each other. They kind of come in at the same, I'm a little crooked there, but they are meeting at the same places, look fairly similar to each other. So it's all coming from the one spot within the ventricles and firing at a rate greater than 100. So it's coming from the ventricle because you can see that they're wide and they are tachycardic. So we are going to call that ventricular tachycardic and monomorphic because they look the same. In 9/4, this rhythm is slightly irregular. It's off by, I think, by 3 boxes. But if you look at it quickly, it does kind of look regular. So, but we are going to figure out the rate. It's about 30. There are no P waves, so therefore we can't do a PRI. The QRS is wide. It's greater than 0.10. It is 0.16. So if you're measuring to about where it kind of comes up here, so that's about 4 boxes. Your QT is measuring from the beginning of that Q wave to where it comes back down onto the isoelectric line. So that is 0.40. So this interpretation is, again, when you're looking at the QRSs, the first thing you should be noticing, what is the QRS? Is it normal or is it wide? This is wide, and that means that most generally that rhythm is coming from the ventricles. So that's part of the rhythm interpretation, is where did the impulse originate? This originated in the ventricles, so it's a ventricular rhythm. It is slow, so therefore it is idioventricular rhythm. So we call this IVR. One of the most important things to remember is that some people will confuse IVR with junctional and know that the difference between junctional and IVR is the QRS. Where does the junction come from? The atrium. So the bottom of the atrium, but the junctional rhythm has a normal QRS. It is regular and it has a normal QRS. The IVR, the R to R is most generally regular, but the QRS is wide because it's coming from the ventricles. This rhythm, 9/16, as we said in the beginning of the ventricular lecture, we said most of your ventricular rhythms you really should be able to see by sight, say what they are, and know what they are. And so this erratic, if you look at the rhythm, it's irregular and chaotic. So you can't get a rate because there's no QRSs, there's no P waves, you can't do a PR interval. You can't measure a QRS because they're absent, so therefore you can't do a QT. So this rhythm is VFib. It's a coarse waveform. And again, so when you see this, this is not something you would waste time measuring or anything. You're going to act quickly, check your patient, check a pulse, call for help, start CPR until the defibrillator comes, and defibrillate this patient as soon as possible and resume CPR immediately. 9.23 in this rhythm, it is regular, and therefore we can do the heart rate. The heart rate is 88. We do not see any P's, so therefore we cannot do a PR interval. So the QRS is wide. You can look at the strip and note that this is a wide QRS, 0.12. The QT interval is 0.40. So we are going to interpret this rhythm as it's wide, so it's coming from the ventricles, but it's faster than an idioventricular rhythm, so therefore we call it accelerated IVR. So anytime you have a rhythm that's greater than 40, between 50 and 100 or 40 and 100, we call that an accelerated IVR or AIVR. These patients sometimes can maintain their blood pressure adequately because of the faster heart rate, but and most times they are transient, such as in a reperfusion of an MI. In the strip 925, you actually have two rhythms within this strip. So you have your basic underlying rhythm, which is regular. So that would be your patient's own beats. You also have another rhythm of V-tach, which actually is regular within its rhythm. So I'm just going to erase these. So what you have is two different heart rates. So you have a heart rate for your basic, which is 100, and your V-tach, which you have the 4 beats and the couplets, is at a rate of 188. So when we talk about P waves, we have P waves for our basic intrinsic rhythm. We do not have any P waves in the V-tach, obviously. So we can do a PR for our basic rhythm. So that PR is 0.14 to 0.16. The QRS is of the patient's basic is 0.06 to 0.08. In the V-tach, that is a 0.12. So these are wider, so they're about 0.12 as well. So we know that they're wide. They're coming from the ventricle. QTs, we're doing the QTs on the basic rhythm. So from and bottom. And so the interpretation is QT is 0.28 to 0.32. So the interpretation is that you have baseline of a sinus rhythm, but you are having a 4-beat run of V-tach and a couplet of PVCs. So again, a couple things you want to look at when you're looking at this rhythm strip. How often are they having these PVCs? And the more that you have, the more runs of V-tach you have, that is concerning. You might want to get a 12-lead EKG. Also, look where these PVCs or these V-tach starts. One concern is if they start in the middle of that T wave, which they are not, but they're awfully close. So we may want to consider suppressing these, obviously. So you may find the provider to order an antiarrhythmic, such as an amiodarone loading dose of 150 and then start them on a drip. So we definitely would like to suppress these, especially if they are continuing and you're having more frequency. This rhythm, 9.28. So this rhythm is considered regular if you actually check R to Rs. The rate is 250. There are no P waves, so therefore you cannot do a PRI. The QRS is varying in width. It's 0.12 to 0.16. And again, when you're looking at this rhythm, you should be able to interpret this from afar. As soon as you see this, your focus should not be on measuring the QRS, but to check the patient. So this rhythm is a polymorphic V-tach. It is considered torsades de pointe. It is not considered coarse V-fib. It is torsades. So you have points going up, okay, and you have points going down. So you have this twisting of, it's almost like a slinky. So it goes in and it goes out. So there's definitely different heights of this rhythm that is polymorphic V-tach. So your treatment is magnesium, 1 to 2 grams. You may have to defibrillate them if they become pulseless. And again, they usually will respond if they have magnesium on board. 9.85. So this rhythm is considered regular, except these PVCs are making it irregular. So the underlying rate is 125 of the basic rhythm. There are P waves, and we can do PRIs, which are normal, 0.12. Your QRS on the basic rhythm is 0.04 to 0.08. The PVCs are wide, so they're about 0.12. The QT interval on your primary basic rhythm is 0.28. So what do you have for interpretation? So if the heart rate is above 100, it's 125, so therefore we are going to call this a tachycardia. Our P waves, our SA node is firing, so it's sinus tachycardia. And we have these PVCs, right? They're a couplet. Now note how you want to describe these PVCs. Do they look the same or are they different? These are different. One is going up and this one is primarily going down. And again, remember your PVCs, your QRS is going in the opposite direction of your T wave. This first PVC, the QRS is up and the T wave is down, whereas the second PVC, the QRS is down and your T wave is up. So these are coming from multiple sites, not the same site. So they are not unifocal, they are multifocal. So that's a little bit more dangerous than a unifocal, meaning that there's only one site within the myocardium that's firing. These are multifocal, so therefore you have multiple sites within the myocardium that has been affected, that is causing these PVCs. So that's how you would interpret this rhythm, sinus tach with couplet of PVCs that are multifocal, or you can call them multifocal PVCs. Now we're going to be doing our pacemakers. So in 10-3, this rhythm, we are looking at this rhythm and this patient has a pacemaker with also in patient's own beats come in. So the patient's own beats, so there's a PQRST, but the patient's pacer rhythms, you can see that there is a pacer spike and there's QRSs that follow these pacer spikes. So with that said, we know that it's capturing because every single pacer has a QRS. Every single pacer spike has a QRS. Now, we know that it is sensing appropriately because first you want to know what the pacer's rate is. So you would measure, between the pacer spike to the pacer spike. How far is that? Now, if you were to see the patient's own beat and you would measure from that to the pacer, it should be the exact same as this, pacer to pacer. So what that means is that this pace beat came in on time. It sensed the patient's own beat, and therefore it came in when it was supposed to. If you were to do the heart rate on this pacer, this is about 48. This patient's own beat from the pacer spike to the patient's own beat is about 83. So know that the patient's own beat came in, which is good because we only want the pacers to kick in when we need them to kick in. So this is a properly or normal function pacer. It's sensing the patient's own beat and it's every time it does fire, it is capturing. So let's take these off. So this is a normal functioning pacer. It is sensing appropriately and it is capturing appropriately. So 10-4, so with this one, the rhythm, the ventricular rate, so you have a pacer QRS, you have a pacer, but there is no QRS. So it failed to capture here. You have a pacer, QRS, and you have a pacer, but no QRS. This QRS is the patient's own beat. So this is an intrinsic beat, which means it's the patient's own. Then you have another pacer, QRS, which kicked in. Then you have another pacer, but no QRS. So it failed to capture here. And then you have the patient's own beat. So we are seeing that it is failing to capture. So let's get rid of some of all this nonsense and let's look at how it's sensing. So when you're looking at your sensing, you're looking at, is the pacer sensing that the patient has their own rhythm? So you would measure between pacer to pacer, what the pacer rate is from here to here. Then look at, so the patient's own beat came in. From the patient's own beat to the next pacer spike would equal the same as this. So this pacer came in right on time, seeing the patient's own beat, and it was sensed it appropriately and fired. Now, it doesn't mean that it always is going to capture, because this is failing to capture, but it sensed the patient's own beat and it did come in on time. So this is an abnormal pacer function, and this means that this patient is failing to capture. So your treatment for this patient would be you need more energy. So if it is a temporary pacer, you would want to turn up the milliamps. So again, if it's a permanent pacer, then it would need to be reinterrogated, and therefore it needs more energy or milliamps to produce a captured beat. In 10.5, so what you have right here is complete failure to capture in the presence of ventricular standstill. So you basically have an asystole, and no matter how, these are your pacer spikes. And again, your pacer is not going to work on infarcted or dead tissue. So if your patient is dead, it's not going to work. So this is failure to capture in the face of or presence of ventricular standstill. So in 10.9, we have, looking at this, we have a pacer, ventricular pacing, pacer, spike QRS, and then you have a spike, but no QRS. Then the patient's own beat came in. Then you have again a spike QRS, and then you have a spike QRS, and a spike QRS, and then the patient's beat came in early, which is normal. But we do have, I'm going to get rid of some of this stuff, we do have a failure to capture. So in this pacer spike, it failed to capture after the second complex. So this is failure to capture. Now we're going to look at it, did it sense appropriately? So therefore we want to know, did this pacer sense and see that patient? So you would measure your intrinsic, or not intrinsic, your pacer rate. So from pacer spike to pacer spike, then you would measure from the patient's own beat to the next pacer, and it should be about the same as the pacer. So it saw the patient's own beat and it fired. It did capture here, but it did not capture here. So this interpretation is that it is ventricular pacing with 2 intrinsic beats and 1 failure of capture after the second complex. In 10.11, you have a pacer QRS, pacer QRS, pacer QRS, and then you have 2 of the patient's own beats, but you have a pacer here. Now there's no QRS that it induced, this is the patient's own, but it's hanging out there and it didn't capture, which is a good thing. And then you continue with pacer QRS, pacer QRS, pacer QRS. Okay, so what does that mean? That means this patient's own rhythm is kicked in, but the pacer did not sense the patient's own beat, so it should not have fired here. Thank goodness it didn't capture, because that could have thrown that patient into V-fib. So this is failing to sense the patient's own beat, or you can say it's undersensing. So when you have a pacer spike too close to the patient's own beat, therefore then we would say it's failing to sense. So it did not sense that beat. So what you would do is you would turn up the sensitivity so that it can be seen a better gain. In 10.13, we have 100% ventricular pacing. That's normal pacing. So you have 100% capture. So every pacer spike has a QRS that follows. The rate of this pacer, again, you would measure from this pacer spike to pacer spike. You probably can do R to R as well, but for the most part, this rate would be the same, and it is 60. So this pacer is set at 60. Now, we see that it's capturing appropriately. Can we tell if it's sensing? Not not really, because we don't see any of the patient's own beats. So the patient's own intrinsic rhythm would be below 60, so that's why the pacer is going faster than the patient's own beat. If the patient's own heart rate went up past 60, then it would kick in, where you would see one of the patient's own beat. But we can't tell if it's not sensing appropriately unless the patient's own beat is in there. But this is normal function, and the patient is 100% ventricular pacing. In this rhythm, 10-14, your pacer, if you look at how fast your pacer is going, it's going at about 60, okay? So what you do have is the patient's own beats, intrinsic rhythms going, okay? Then you have, get rid of that, then you have a fusion beat, which is basically the patient's own rhythm tried to come in, and at the same time that the pacer is sensing that there was no patient rhythm and trying to fire at the same time. So what that does is it makes, you do see a little bit of a pacer spike, you still see a P, so it's trying to pick up and pace the patient because it didn't, it sensed it, oh, it didn't go, so, and the patient's own beat came in right when the pacer was kicking in. So this is normal. So you can have fusion beats, but it's just basically happening at the exact same time. And then again, it carries on with a pacer rhythm. So this is normal function with third and fourth complexes or fusion beats, and they kind of go into a paced rhythm. And 10-3-3, this is a ventricular paced rhythms, so two pacers with a QRS, so captured. The patient has their own. And then the pacer came in, and what happened here is, again, you have another fusion beat, which is the blending of the patient's intrinsic rhythm and a paced rhythm, or a paced beat, and then it goes into paced rhythm. So this is a normal functioning pacer, and coming in, it's sensing the patient's own beat, it's coming in on time, and it's capturing appropriately. So if it wasn't sensing, again, you were sensing, you're going to see what the pacer rate is. So when you're doing from the patient's own to when the pacer came in, this would match what the patient's pacer rate is. If this wasn't sensing appropriately, it would probably have come in, again, too close to the patient's own beat, but for the most part, it did sense, it came in on time, and a normal functioning pacer. For the last strip, 10-39, this rhythm is a pacer which is set at about 70. If you go pacer spike to pacer spike, you can do your heart rate for that. Now you also have some of the patient's own rhythm. So in the patient's own rhythm, you can do your R to R, which comes in at about a heart rate about 107. With this, your interpretation of this rhythm, it is a normal functioning pacemaker. So it is capturing when the pacer spike comes. It's sensing when the patient is having their own beat. So it's the distance is the same distance from if you were to do a pacer spike to pacer spike. So, whoops. So it is measuring the correct distance. So it fired when it was supposed to. So it's sensing appropriately. So it knows when it's supposed to kick in. And it's capturing. So every paced beat has a captured beat. And this is a normal functioning pacemaker. This concludes the review of the homework for the AV blocks, ventricular, and pacemakers.